Well, good morning, everyone. Thank you so much for joining the LeadingAge Virginia Coronavirus Weekly Member Update Call. Before we get started, I wanted to remind everyone to please register for the LeadingAge Virginia Virtual Capitol Hill Lobby Day. So typically, we meet with LeadingAge National in Washington, D.C., and meet with representatives in the House and the Senate. This year, we're going to be doing it virtually. So we need everyone to register by March 26th. This is not an all-day event. Once you register by the 26th, you will be matched up with your representatives, and then we will have virtual meetings. So once you register, there will be some training, and it's going to be probably at the most an hour and a half of your day. So I really hope that everyone will go ahead and do that. I have put the link in the chat box. This is a free and virtual event. Next slide. So thank you, Craig, for joining us to provide us with a Virginia Department of Health vaccine bridge update. So over to you, Craig.
Yeah, thanks. Good morning, everyone. Pleased every time I have an opportunity to address stakeholders in this manner about such a critical topic. So I'm here to provide just a little information around by way of an update on the Commonwealth's efforts to meet ongoing needs, to coordinate to meet ongoing needs for long-term care facilities in the wake of the CVS Walgreens clinics drawing to completion. And before or until such time that the normal pharmacy infrastructure in Virginia can incorporate the COVID-19 vaccine to meet ongoing needs through normal processes. You'll recall there are two strategies involved here broadly. One is to coordinate to meet those ongoing needs. We'll cover updates on that one first. The second has to do with incorporating the COVID-19 vaccine into that pharmacy infrastructure. I have some input or some updates there as well. With regard to meeting those ongoing needs, we continue to work through Pfizer second dose needs that are either due or slightly past due. I do know there's a lot of concern out around kind of past due and what that looks like. We are working as hard as possible to meet those needs. Finding out about some of those needs is a challenge. And sometimes by the time we find out about them, they're already significantly overdue. We did seek one question we had found as late as last week is, what if you exceed the 21-day or even the 42-day window? And CDC does provide in their clinical guidance for the mRNA vaccines, not in the normal body of the page where one might expect to find it, but instead in Appendix A, information that a second dose exceeding the 42-day window is still valid and doesn't need to restart the vaccine series and doesn't require any additional reporting. Now, it's our goal to be as close to the due date as possible with all of those. It is incredibly difficult to coordinate those second Pfizer doses, particularly in small quantities. But we are working it 10 hours a day, every day, from now until they're all met. We are working through particularly the ones that were due last week, are due this week, and will be due weeks into the future, working with local health districts to meet those needs. We are finding that the majority of local health districts are very happy to work with us. They in some cases appreciate our coordination and in some places not. But if you do have outstanding Pfizer second dose needs, I would encourage you to reach out to your local health district for assistance there. We are doing that from our end, and hearing about those needs from both ends certainly can't hurt. Vaccine series starts. We know that there are many new staff and new residents in facilities across the Commonwealth as well. We have vaccine on the ground this week, beginning to meet those needs. Virginia was able to leverage a brand new pipeline of vaccines. So last week we received the potential to divert 1,300 Johnson & Johnson vaccines through the federal pharmacy partnership to a group purchasing organization named Cardinal. Through that process, we appealed to about 30 of Cardinal's pharmacies in Virginia to identify those that were willing to step up and help us meet this need in long-term care facilities this week. About 10 of those pharmacies responded to that appeal favorably. And this morning at 9 a.m., those 1,300 Johnson & Johnson doses were ordered to arrive at, it looks like 8 pharmacies across Virginia. I've spent the morning today, most of yesterday, and will continue tomorrow, matching up known needs for the vaccine, particularly series starts, so first doses, with those pharmacies and those doses available. And we have other pharmacy partners willing to help there as well. And so Moderna series starts, I know you've been waiting for a while for them. They are coming online this week and will continue throughout next week. An important thing that we're running into with looking to make these connections, believe it or not, as silly as it may sound, is an eyes-on snapshot look as to what that need is. I am aware there's an awful lot of need out there, but I honestly, I don't have a good window into some of that need. Previously, we had used the REDCap survey that many of you are aware of, and the REDCap survey still does exist, and you can still submit need through that. The challenge with that survey is it becomes out of date basically the moment that you press the submit button as you take a new admission the next day or hire a new staff member or what have you. And so to support this, our partners over at VHCA and VCAL have launched a new platform. I understand that the LeadingAge Association has some documented information around this as well. The URL's there on your screen. It's apps.vhca.org/smart/login. This is open to all nursing and assisted living facilities in the Commonwealth, not simply VHCA members. It is a very simple platform. Your first login, you simply choose your facility from a drop-down menu. Your password will be the zip code that is on file with your licensing agency. And it is a very simple way for you to report on a daily basis what your ongoing vaccine needs are. I have been working primarily from this mechanism because it is the most recent data that I have to identify and link these needs. I still am referring to the REDCap data, but many of those were submitted long ago. And as I call to verify and validate those needs, in a lot of cases, they have changed sometimes by a factor of 10. So I encourage all facilities on the call to head to this link. This is not necessarily a replacement of the REDCap survey, and that begs the question as to which one to use. I do think over time, transitioning to this new VHCA tool is the best path forward. Both tools will remain operational in order to try to collect every need that we can become aware of so that nothing falls through the cracks. But we do anticipate, because of how easy this one is to use, we do anticipate this becoming the primary tool over time. So again, please do access that immediately. You can update it daily. It's extremely simple to update, and I am checking that multiple times a day. Final note for strategy one, and we mentioned this last week and took some feedback on it. We did instruct CVS and Walgreens to cease offering Pfizer first doses at their third and final clinic. I was able to get a list from Walgreens with regard to what facilities still had that scheduled so that I could make those calls. Again, trying not to cause an unexpected delay or a sudden change in the plan. And I was able to communicate with all but a couple of those. I've got a couple calls still to make for people who didn't have second dose, didn't have final clinics scheduled until next week. So I'll be making those calls proactively this afternoon. If we can go to the next slide, my last slide, I believe. For our second strategy here, you'll remember that getting the normal long-term care pharmacy infrastructure up and running with the COVID-19 vaccine is the long-term solution here. And to that end, our progress is continuing pretty well. We still are on target for any facility serviced by Omnicare as a normal pharmacy contract to begin to have their ongoing needs met by Omnicare by the 1st of April. Again, if you've not already received the information from Omnicare in that regard, please do reach out to your point of contact there. I don't expect that Omnicare is going to ship vaccine to every facility in Virginia, say on April 2nd or April 3rd. But they have been planning this for quite some time, and I do anticipate potentially by the end of next week they are able to meet the needs for their customers in an ongoing fashion. Similarly, and I hate to name drop necessarily, but similarly, I know that facilities engaged with Remedy Senior Care are in a similar situation, and I've engaged with conversations with several more long-term care pharmacies in Virginia to make sure that this is set up and as operational as possible in the beginning of April. And so, again, good progress there. If you've not reached out to your pharmacy yet, I encourage you to do so. Simply inquire as to how they plan to meet your ongoing needs as soon as they can. If you speak with a pharmacist a pharmacy that has not spoken to somebody at VDH about this, do give them my email address. Just like many of you, some of these pharmacies submitted the intent to provide vaccine form long ago and haven't heard anything back. And it will take sort of my focused attention to get them escalated to the enrollment team and processed. I am aiming to do that as soon as I can, but if you identify somebody who's not been tended to yet, please do have them reach out to me, and I will prioritize that immediately. An additional detail there, you will very soon, likely within the next week, begin to see a push of information from VDH to begin submitting for intent to provide vaccine for enrollment to become a vaccine provider for all of the facilities in Virginia that have qualified and competent vaccinator staff on as part of their clinical team. Many of you have begun that process already. If you've already submitted the intent to provide vaccine form on VDH's website, you do not have to do it again. They are still in the queue, and they have been for the last several months sort of deprioritized while the enrollment team looked at other groups. Now we have finally come to the forefront of that prioritization, and there will be a concerted effort over the next couple of months to process enrollments for long-term care facilities. When we finally get to that golden day, facilities will be able to receive redistribution of product from their pharmacies, report the administration data into the IIS, and that really is the long-term solution here that will carry us from whenever that materializes to the point where the COVID-19 vaccine is no longer a scarce federal resource under EUA and can be ordered sort of through normal channels. If you have not started that process, the intent to provide vaccine, I did just drop the URL into the chat. So feel free to click there. You can find several bits of information about the process there. The first step is the submission of that intent to provide vaccine. And again, there's a team at VDH currently building the project that will begin executing within the next week to enroll long-term care facilities as providers in mass. I think that's probably my last slide.
Craig, and I'm sorry, I didn't properly introduce you. Would you mind sharing how you have in your email line that you are on loan to the Department of Health?
Yeah, sure. It's always
working just with this program.
Yeah, it's always funny when chat messages come in and you kind of see them out of the corner of your eye when you're talking. And the one I saw was, "Who is this talking?" Right. So my name's Craig Camage. I'm typically the director of the Office of Emergency Management for the Virginia Department of Behavioral Health and Developmental Services. And through an interesting series of events, I have detailed over to the Virginia Department of Health specifically to assist with this project. And so my only work all day, every day is this bridge program that I've just updated you on. And so, yeah, that's who I am. We did have a couple questions come into the chat. Okay to address those now?
Yes, absolutely. Go ahead.
So who am I? We covered that one. There's a question. What if we can't provide ultra cold storage and don't have Viz access? So a great question. And I'll assume this is coming from the facility perspective. And this will be sort of a short-term solution and then a long-term solution. The short-term solution is your long-term care pharmacy will look to do one of two things: either arrive on site at your facility and administer vaccine if they're capable of doing that, or if your long-term care pharmacy is, for example, Remedy or Omnicare or Express Care or a multitude of others, they will execute an agreement with the facility that outlines how you will store, handle, and manage the vaccine. And then they will dispense to you via standard delivery the quantity of vaccine that you need. They will not be dealing in the Pfizer product throughout any of this. And so there is no concern around ultra cold storage. And the Moderna product or the Johnson & Johnson product is what you will receive. It can be stored in a standard fridge for until you use it. You will very likely not be able to get any vaccine until you have enough need to use up a whole vial. And so because of that, I don't anticipate you'll have any need to store the vaccine more than a day or two. You should be well positioned to administer anything you receive really immediately upon receipt. They will deliver the ancillary supplies that are required as well, syringes, et cetera, et cetera. I don't know everything that's in the kits, but I'm told that the ancillary supplies that ship with the vaccine include everything except gloves, Band-Aids, and sharps containers. And so you should be pretty well positioned for that. Now, the second part of this question has to do with VIIS access. And during this short-term solution where facilities are executing agreements with pharmacies and conducting the mechanism I just covered, the pharmacy will maintain the burden of reporting into the IIS. What that means is that part of that agreement will detail how the facility will provide person-level information to the pharmacy regarding who's receiving those doses and when, and those pharmacies will enter that information into the VIIS system. When we pivot toward the long-term solution that I covered a few minutes ago, that is the enrollment of long-term care facilities, the main difference in that is that when that enrollment is complete, facilities themselves will have the burden, for that reporting, and that absolves the pharmacies from doing that. Which you can imagine, if a pharmacy is serving multiple facilities, it is reasonably burdensome for them. And so that's the answer, I think, to that question, Ryan. Feel free to send something else if something's left unclear. Another question here. I mentioned EUA. Is there any plan for Pfizer, Moderna, or Johnson & Johnson to obtain full FDA approval? Listen, I'm sure that there is. I don't have eyes on that, and I haven't had a chance to kind of come up for air long enough to seek the best situational awareness at that level recently. I did ask CDC the other day on an office hours call, because once that frees up, a lot of the rules that are complicating our lives right now go away, and our typical pharmacy contracts take over, and then everybody's life gets a lot simpler. They had no forecast as to when that may happen, which means I doubt that it's even being discussed as an immediate potentiality. I almost guarantee that all three companies will seek full approval. What the timeline looks like for that, though, I don't have any intel on. I wish I did.
Well, Craig, thank you so much. I'm not seeing any other questions in the chat box, but we'll be following up with you, and we'll continue to provide any updates on the program in our weekly updates, as well as on our weekly member calls. So thank you so much. We appreciate the update.
Thank you.
Next slide. So the governor yesterday announced some updates regarding relaxed restrictions. So I am pleased to introduce Alicia Cundiff. She is the government affairs specialist with the lobbying firm that LeadingAge Virginia works with, Spot Fane. So thank you for joining us, Alicia. Over to you.
Hi, everyone. Thank you for having me. So yesterday, Governor Northam announced several relaxed restrictions that will begin April 1st. And specifically for independent living and everyone here today, the social gatherings relaxed restrictions are probably the most relevant for you all. And that is 50 people indoors and 100 people outdoors. And I'll go over briefly the rest of the restrictions. They're not really specific to facilities, just for the general public and just general awareness. But Dana can also speak to how this social gathering limit can be used in your facility setting. But moving down the list, entertainment venues, so that would be like concert venues or Professional and college sporting venues can be at 30% capacity or 500 people for indoors. And then for outdoors, they can just be at 30% capacity. There's no numeric cap. Recreational sports venues are like high school stadiums, for example. That can be 100 spectators indoors and 500 spectators outdoors. And graduation events, I'm sure that you've all seen in the news a lot of Virginia universities wanting to be able to hold their graduations like normal this year when they had to cancel them last year. That's 30% capacity or 500 people indoors, 30% capacity or 5,000 people outdoors. And then lastly, wedding venues. The governor has distinguished wedding venues from entertainment venues and had a tighter restriction on them because these tend to be large family and friends gatherings where people are coming into close contact and celebrating a wedding. So that's 50 people indoors and 100 people outdoors. And he said yesterday that he made all of these relaxed restrictions with the hope that people will continue to get vaccinated as cases continue to decline. Our state positivity rate is about 5.6% right now, he reported. So as long as things continue to move in the trend that they are, these will be the restrictions in place, and then hopefully there will be able to be more that are even more relaxed. And I'm going to put in the chat the full updated executive order so that you all have access to that, and as well as just a helpful article from the Richmond Times-Dispatch just overviewing everything. So Dana, do you want to provide some more insight into how they can apply the social gatherings element?
Well, I think that, my thought would be that I know that as independent living, not being a regulated level of care, with the exception of those independent livings that choose to be licensed through the Department of Social Services, I know that with the social gatherings restrictions, that is what the Department of Health has told us to rely upon when it comes to independent living level. But I know that everybody's doing what they need to do to keep their residents and staff safe, and doing what they need to do to loosen up, some of these requirements. And so I don't have a hard and fast answer for you at the moment, except that the Department of Health has said that independent living should follow the social gathering parameters. So with that said, we have invited Goodwin House to be a part of our call today to offer us some perspective on how they have been handling dealing with loosening these restrictions in their independent living level of care. So I'm pleased to have Barbara D'Agostino. I'm sorry I messed up your name there, Barbara. I'm going to hand it over to you to introduce yourself and share some perspective with us. Thank you so much for joining us.
Thank you. And my understanding is the appropriate way to pronounce my name is D'Agostino, even though my husband's family all pronounced it D'Agostino, and I didn't learn the proper way until I went to Italy.
I'm
So, D'Agostino, but thank you. Thank you very much. I was asked to talk about loosening restrictions regarding dining in independent living. And I imagine most of you feel as good as I do about having the ability finally to say yes to our residents. For months and months and months, over a year, I feel like I've been saying no to almost everything, and we try our best at Goodwin House to say yes. So it's nice to start to see the opening and see our residents out and about and getting together. For those of you who aren't familiar with Goodwin House Alexandria is located in Alexandria, Virginia, and we are right outside of the District of Columbia. And we actually have two communities. Our other light plant community is called Goodwin House of Bailey's Crossroads. So we are very fortunate in that we come together. Two heads are better than one. We come together. We used to do it daily. Now we're doing it weekly to discuss our protocols and just how we're going to open up safely. We call our team the IPP team. It stands for Infection precaution and planning. So we looked at reopening, and it was based on our vaccination rates. And Goodwin House Alexandria had their second dose of the vaccine, and we're 2 weeks beyond that, about a week before Goodwin House at Bailey's. So because of that, Alexandria opened up dining March 8th, and Bailey's opened up dining the following week, March 15th. So what I thought I would just briefly go over with is how we did this in a safe manner, talk a little bit about room service, takeout dining, and in-person dining. Regarding the safety mechanisms, we are not allowing any family members into our dining rooms at this time. We hope to do that in the near future, but we are taking baby steps. We want to make sure we're doing everything in a safe manner. So right now, no family or guests are permitted in our dining venues. When our residents do come into dining, we take their temperatures upon entrance, and we also ask that they self-monitor themselves and do not come if they're not feeling well. Masks, of course, are required in the dining areas at all the time, except when they're actively drinking and eating, and that's a challenge because once the masks come off, they tend to stay off. So that's been a little bit of a challenge. We are continuing with room service. Prior to the pandemic, we wanted most, if not all, of our residents to come out to dining for the socialization. So we would charge for room service. Due to the pandemic, when we started the room service, we discontinued those charges. We've not started them again, but I imagine when we do, more residents will be coming out to dining. But right now, we're continuing with room service for all 3 meals. We're also doing takeout, and we're also having residents come to our dining room. So we started this 2 weeks prior to our grand opening, basically, by doing a soft opening. And it was mainly in our Fillmore Lounge, which is our bar area. And we just did it 3 days a week. In the evening, right before dinner time, and we offered some mixed drinks and tapas. And we didn't charge residents for this because we're trying to encourage them to come out. And we did this with a maximum capacity of 10 residents. We are offering self-service coffee in the morning, and we did this prior to opening. And also we have free frozen yogurt for the residents, but with the yogurt, we are assisting them with that. With our takeout, we do have reusable takeout containers. Probably like most of you, our paper goods and dining costs have gone out of the roof. If residents are on quarantine, we do use the paper, but we do have a reusable green container. So when we do the delivery, we deliver these containers to the residents, and we can rewash them and reuse them. So right now, we have residents coming to our bistro for breakfast and lunch. We're only using 1 dining venue for the breakfast and the lunch. And their server, it's a buffet line, but it's server assisted, and we serve both hot and cold stations. So the resident buffet makes it sound like the residents are serving themselves. They are not. We are serving them. If they take out to the rooms and they pick up, we put them in those reusable green containers, but they're able to pick out the food they want from the serving line. So we do have a number of residents that still like to come down, get their food, and go somewhere else. So we are offering this in our bistro Monday through Friday for breakfast and lunch. We do our dinner in another dining room. It's we call it the Alexandria dining room. It's more of a formal dining room, and we do require reservations. Right now, we have been operating at a 25% capacity. On Monday, we hope to increase this to a 50% capacity, but my understanding from the guidelines that have come out is it's not so much a percentage, it is that you space people 6 feet apart. So that's been a little bit of a challenge too, because most of our 4 tops now have become 2 tops. So as of today, we are providing dinner in our Alexandria dining room on a first come, first served basis. And again, that's Monday through Friday. Starting this coming weekend, we are going to start opening up for the weekend. We also, when the residents do sit down in the dining room, we are offering the single-use paper copies of the menus. So we're not using our typical menus. Right now, I could actually tell you the stats. You give me 1 minute. Right now, we have so far for dining when we open, for the first day, we had 10 residents, and I have 450 residents, about 300 in independent living, just to give you an idea. So for the independent living residents, for the first day, we had 10 come to our dining room for dinner. On Tuesday, we had 14. On Wednesday, we had 25. Thursday, we had 31. And Friday, we had 32. So the numbers are starting to creep up a little bit. And like I said, starting next Monday, we're going for the approval for our IPP team, which is a lot of our clinical staff. We hope to open up our dining to 50% capacity. And then finally, we are going to be offering a lot more outdoor dining, as I imagine a number of you will. Last year, we purchased a number of heaters so that we could do this. So we will continue doing that on outdoors. And I welcome any questions.
Thank you, Barbara. We do have a question. Although you're not allowing visitors in the dining room, are you allowing caregivers to sit with and assist residents in the dining room if needed?
Well, we really don't have anyone now in independent living that has a caregiver that would be doing that. With our other levels of care, they are not sitting with them. I just actually did rounds in healthcare, and we have small houses. I did not go through every house, but the houses that I did go through, there was no one sitting there. But if a resident needed assistance with feeding, absolutely, we would have a staff member help them.
Thank you. Another question, are you limiting any dining and participation for residents having had travel with family for overnight visits? These would be fully vaccinated residents.
No, we just loosened our restrictions last week due to the CMS guidelines. We had been requiring a negative COVID from family members prior to visiting. If it was healthcare or assisted living, they needed to have a negative COVID within 7 days. And if it was independent living, they needed a negative COVID test within 10 days. But once CMS came out with those guidelines, it didn't make sense to be more restrictive for our residents than our other higher levels of living. So we are encouraging, but we are not requiring the vaccine or the COVID test for all levels.
Another question, do residents bring the reusable takeout containers back to the dining room when they are done, or how do you receive them back?
We have some green containers on every floor, and it's actually in our trash room, and they're green. So that's where the containers go. And then our dining staff picks them up from there and brings them back to dining to wash.
Well, thank you, Barbara. That was really helpful information. I wanted to invite Ben Uncle, who has joined us, to see if he had any perspective to add from what they're doing at Westminster Canterbury at the Bay.
Hey, thanks, Dana. At the Bay, February 20th was the day that was 14 days after 100% of IL and AL residents had their vaccines. So February 20th was kind of our freedom day. So we've gone a month now with dining fully open and people unmasked while they're actively eating, and no infections, and all the data we're following from Israel, where they have the real world experience of mass vaccination ahead of us of the old, indicate that the vaccine is very effective among older folks. So they've been so long without socialization that we feel very strongly, that we needed to go to wide open dining services for socialization. What we don't allow is outside guests because we're not set up to verify that they've been vaccinated. And I trust the vaccine more than I trust, the tests that were 2 days old or 3 days old or whatever. So anyway, that's the approach we've taken. It's been a long struggle. A lot of them were struggling. We have a lot of transfers to higher levels of care that have occurred more than normal this year as we come out of it. So I see the toll of social isolation and feel very strongly that the vaccine works in the old. All those scientific indications are that way. And so we've opened up dining fully indoors, no guests though. And we charge for room service delivery now like we used to before.
Thank you, Ben. A question has come in. Do you allow people from multiple rooms to eat together in long-term care, or is this all in independent living or assisted living?
It's all in independent living, these rules I'm speaking of, where we feel prohibited by regulation from some of this in skilled nursing, although we are spacing people liberally and having them eat together in our nursing center. But we're much stricter about reconvening them into community dining in the nursing center than we are in independent living.
Well, Barbara and Ben, I want to thank you so much for sharing what you all are doing in your communities, and hope that we can continue the discussion this morning as we move to talking with LeadingAge National about some of the resources they have in place and some of the struggles that they're hearing from other members across the country. So with that said, thank you, Dee Percoin, for joining us with LeadingAge National. I want to hand it over to you now. Thank you.
Wonderful. It's so great to be with you all. And I do have some resources to share. Also, I know Ben and Barbara both quite well, and it's a delight to share the microphone with them today. So I thought I might start off with a couple questions for both of them, and then anybody else on the call who would like to chime in. This will not sound new or unusual to you all, but what we're hearing from members across the country is exactly what several of you have referenced, pressure from independent living residents, especially to get going on reopening, and especially getting together in groups, visitors, and so forth. So I thought I'd start with a couple questions for Barbara, for Ben, and anybody else who would like to share. And then I'll kind of jump into what we're hearing across the country and some resources I can offer you all. So the first question is, what dialogue are you having with residents about their desire to know the vaccination status of people who are not residents, like staff members, visitors, and others who might be in your spaces?
I could answer that one, Dee. We send out a weekly communication to all of our residents, and then we send a summary of that to all of our family members, so they're aware of our protocol. In that communication, we let them know any cases that we have had, and we also let them know our vaccination rate. So they're very aware. However, right now we're at 99.5% residents and a little over 90% of staff. We are not giving them the names of staff that are not vaccinated. Some have asked; they want to know if their housekeeper's vaccinated or not, because they don't want to have a housekeeper that's not vaccinated. That's what I've heard. But we're not giving out that information. But if a staff member is not vaccinated, we're having them wear an N95 mask and a face shield. So I guess that's one way, that would indicate to residents that it is an unvaccinated staff member.
Thanks so much, Barbara. That is something that I've heard many members say the same. And it really boiling it right down to housekeeping and dining room servers, especially anybody who's coming into close proximity. I want to just share, we had a wonderful webinar with Dr. Michael Gillette a couple weeks ago through LeadingAge. And I encourage you all to check it out. I'll put the link in the chat, where one of the case studies was on this particular issue, the ethics, if you will, of how to protect staff and their privacy, how to honor residents' desire to know, while reinforcing that, of course, it's not their right to know the particular medical information, vaccination status of a staff member. It's a very fine line to walk. And of course, it sounds like so many members are doing that very, very well, just walking straight down
Dee,
that
can I
line.
add something about how we balance that at the Bay?
Yes,
If
please.
we put it on the badge if you've been vaccinated, but you don't have to get the badge that telegraphs you've been vaccinated. You get some extra privileges if you do. So there was some incentive to, voluntarily declare yourself vaccinated. We thought it was a good reinforcing, but we made clear to residents that you have to accept the server that we give to you, and the server is going to be double masked. But you can't pick and choose your server or refuse service. If you refuse service, you just refuse service. Nobody else is going to replace the person. But we did, to self-reinforce the high vaccination rate, decide and to provide comfort to go ahead and let people mark themselves vaccinated on their badge, get a new badge. So it's still voluntary for the staff. We got over that problem of forcing them out if they got a vaccination. So that's the way we balanced that. And we said to our residents, you can know, but you can't refuse service.
Ben, thank you so much for sharing that. That's a really unique approach, and appreciate hearing that other perspective as well. Because that is, as I mentioned, this fine line that we continue to try to balance. So thank you so much. My next question, and then I'll dive into some resources, is how do you plan to handle visitors, especially related to vaccination status and moving about in your spaces or in your private residences with your residents?
I don't know if Ben has a comment. I can start with that. We did pull back on that. As I stated earlier, we were requiring COVID tests for all levels of living. And with the new CMS guidelines, last week we pulled back on that. So we are not requiring any type of vaccination or COVID test, but we are encouraging. And if anyone wants one, we'll do a rapid test right there for them. We also, on March 1, opened up visitation to resident apartments, and that's made it a lot easier. So they have to sign in, but we're limiting it to two visitors at a time, and they're supposed to go directly to the apartment, directly outside, and not walk through our community at all. We have not allowed the visitors up on our higher levels of living yet, so we bring them down to certain areas in our common areas to meet with their family members. With one exception, we did early on open up in healthcare, where if it's an existing independent living resident that was fully vaccinated, we're allowing them up to the healthcare to visit their spouse, and we're not limiting that at all. We're not limiting them in time or days. I know some communities have been doing that, but we really want to see the spouses engage with each other. So we are allowing it without any limits.
At the Bay, we follow the rules for the nursing center. So we still have visitation stations, and a lot of that changes based on citywide infection rates. But in independent living, we try to follow the KISS principle and keep it simple. So after February 20th, the only rule for guests is that you have to wear your mask. Because again, 100% of the people we care about protecting are vaccinated. And if they want to add to their own protection, they can be both vaccinated and masked. I'm talking about our vaccinated residents. And so we know we can't regulate what goes on behind closed doors, so we didn't even try. But we also made the decision there's no honest way to verify whether somebody's been vaccinated. Therefore, we're just going to make them wear masks, knowing that our residents are 100% vaccinated at the independent living level of care. So that's the way we approach it. Just simple. Guests could come on in, but you better be wearing your mask. And if we catch you without a mask in common spaces, you'll be banned from the campus for a period of time as a guest.
Well, wonderful. Thanks both to Ben and Barbara. And again, if anybody wants to share in the chat also what they're doing, I think this is one of the great benefits of LeadingAge membership is learning from one another. You both have shared some very creative and I think innovative solutions to managing really thorny issues that across the country members are really struggling with. So Ben and Barbara, thank you so much. I'm going to just jump into sharing a few resources. And then again, if we have more questions at the end, they're very, very welcome. So common themes, you can see them listed here. And again, special thanks to both on talking about what you're doing in your dining rooms and public spaces. I would say, I hear from members across the country that they're on this sort of teeter-totter, trying to figure out the right side or the balance of issues of public use, movement of people in spaces, how to mix and mingle folks of differing vaccination statuses until we get to that point, hopefully, where everybody has access to the vaccine and has received it who wants it. Social distancing, let's start with that. I hear a variety of approaches, in terms of, yes, we are going to socially distance, or no, we're not. We're going to base it on how vaccinated our resident population is. And if we're at 100%, then we're not going to do social distancing anymore in our public spaces. Keep in mind, some of this comes from other states where there are different parameters in place around what is allowed indoors. Buffets with servers, similar to what Barbara was talking about just now. Having the buffet open so residents can see what's available and they can choose, but the servers are only the ones who are actually selecting the food from the serving trays. Others have decided to just completely go without a buffet. Having reduced capacity, in accordance with state guidance, whether or not to have masks at the tables. People fall on both sides of this. Yes, we are going to require masks except when they're eating, or no, once you enter the dining room, you don't have to wear a mask. But, that's because we're not letting visitors in or anyone else who's not vaccinated. And our residents are all vaccinated. So many of these decisions based now on that vaccination status of people. Some are keeping their deliveries up and running. Want to encourage residents, if they're not comfortable yet coming out to the dining room, to still have meal service. Others are saying, nope, we're going to end the end of March. We're stopping delivery and going straight into service in the dining room or other spaces. And the rationale behind this is, some members don't have the staff capacity to maintain both, to keep doing delivery and keep the dining room open. Cohorting, some members in the past had been setting up sort of small group pods amongst their independent living for sitting together at tables. And some are deciding to continue with that. So you can come and be in the dining room together, but only in your pod or in your cohort. Whereas others are saying, nope, we're getting rid of that now. Everybody's or most are vaccinated except for 3 or 4 residents, so we're going to go ahead and just let people mingle. All by reservation. I actually have not yet heard a member say, especially for dinner service, that they're not requiring reservations in their dining rooms, just to continue to.
At the Bay, we're not. Dee, you can make us the first.
All right. Well, thank you, Ben. Ben is the first member, so that's a change I'm sure we're going to see as we move forward, as communities start to loosen up those restrictions and try to manage their flow of people. So Ben is at the forefront. Thank you, Ben. visitors.
Well, I don't know if I would say the forefront. You said you haven't heard of one. We're just one. Forefront or back front, depending on your perspective. But anyway.
So that's, that is a decision point that folks are going to have to come to it pretty soon, because as we're talking about, pressure from especially independent living residents, that's one of those areas. Many want to go back to that more come in and just be seated approach that they were used to before. So you're the first to, or at least that I've heard of, let's say, to tackle it. And hopefully it goes well and we can learn from your example. Moving into some of these other areas, not to belabor any of them, because a lot of the same decisions and dichotomies exist, in those common areas or public spaces. Do we let residents gather with visitors publicly where we can keep an eye on them? That's been part of the rationale in some communities, but not go back to private apartments where, as Ben said perfectly, you don't know quite what would happen behind closed doors. Or on the flip side, not opening up those public gathering spaces yet, but allowing visitors to go up to apartments or into cottages with visitors so they can have at least those visits privately in a smaller group. And there's I would say, an even balance and even rationale of both, to try to either manage the public spread, or to at least be able to keep an eye on who, how people are interacting. Are they keeping their masks on? Are they socially distancing? It's a decision, just like, the examples of Barbara and Ben, that each community has to come to, knowing your population and knowing what works best in your space and what is safe in your spaces. Transportation was an interesting point of discussion that came up in another member call. One I hadn't heard yet. People talk much about whether or not to resume the social parts of transportation, going out together, shopping, or to events as they start to resume. Some communities have said, nope, we're not going to do any kind of social transportation. We will do errands for people, run to the grocery store. Our residents love that. In other situations, they've resumed shuttles. Some of our members have nice little downtown areas, and especially if the weather is nicer where they are already, taking them downtown where they can come and go on the bus, keeping it socially distanced while they're on the bus, but giving that opportunity to get out and be out and about again. We've talked pretty well about visitors, but I've heard a few approaches similar to the examples that both Barbara and Ben have given. Some have what they call a designated visitor program, which is similar to what Barbara mentioned, having only one or two visitors who can go up into an apartment or go to a cottage and visit. Or some have started a vaccinated visitor program, and that would be the visitor demonstrating their vaccination status, two doses plus the time to wait after. And then they get a special badge or a special access card that lets them into the community unrestricted. And the idea there being, once you have your vaccine as a visitor, you can move about freely. And then, of course, many are still continuing that testing and screening regardless. So I would say it boils down to, as I have here last, that vaccination status question. And how do we use that information? How do we protect that information? What works best within our communities? If we can go over to the next slide. Let me pause a minute here. I was not yet looking at the chat. Has any community with an IO component had IO residents challenge the ability to restrict them since they're in an unregulated area? That's a great question. I would say yes, definitely. I was having this conversation with some folks in the Maine, New Hampshire LeadingAge group, and one member gave the discussion point. She says we try to emphasize a we mentality, not a me mentality, when these kinds of conversations come up with residents, emphasizing, we're doing this for the collective safety of all. I've noticed a shift in the conversation myself. I've observed this a couple times with different groups, that where we used to be talking with our general public and saying, please, socially distance, please wear your masks, help us protect our older adults because they're vulnerable. Now we're almost having the opposite conversation with our IL residents, about why it's so important to still have these precautions in place, even though, they're all vaccinated. There's still community members who are not because it's not accessible yet. Staff members, same thing. If they've got a medical reason or a religious reason why they're not getting that vaccine, it's still important that we protect everyone. And so that conversation has shifted to having it with our residents to say, now we need your help to protect everyone by still engaging in some, safety precautions that will work for our community, that will help us keep everyone safe until the vaccination is abundant and widely accepted. Here's a few resources that actually we put together last year. I'll just very quickly touch on what they are. We're adding more as we go along, but the last two especially may be helpful to you. I'm going to show you some highlights in our slides here in just a minute. Also, coming in early April, we're going to be having a special meeting with the CDC that I've asked for because there is this gap for independent living. To know how to handle some of these questions. Members are just like Barbara and Ben and many others, having to figure it out on their own and come up with solutions and which work and which keep people safe. And that's at the end of the day, the most important thing. But we're asking CDC to understand and recognize that we need some more behind that, especially when residents are challenging us and pushing us a little bit and pressuring for these changes. To have that backup from the CDC to say, this is what's recommended specifically for our setting, not just for the general public, not just for healthcare. So when we have that date, we'll be sharing that broadly. I encourage you to come. It will be probably the first full week of April. So if we can just kind of go to the next slide, I'll show you quickly. So this is an example from the infographic. And you can see the green highlighted areas. These are all links that will take you to important agency websites like the CDC, the FDA, and others. I put this together back in the early summertime just to identify some of the core issues in these areas that we are challenged to reopen. Of course, the twist now again is that vaccination status, but the actual operational considerations, the infection controls and considerations, even the people management considerations are pretty much the same. If we can go on over to the next slide. You'll see some examples this is from the quick cast that I put together on reopening dining rooms, pulled together the CDC and FDA guidance to try to make that patchwork quilt for you of, what do we know from these sources that we can apply to our setting. If we can do the next slide. And this is just, again, within that quick cast. These are the resources that I've highlighted for you. You can click on them. It'll take you directly there to get more specifics. And of course, you can listen to the whole quick cast, which will take you through each one in turn. And then if we can have the next slide. I am also in the process of doing a quick cast on design and architecture for post-COVID spaces and places. And I wanted to share with you a couple of those pages. We won't have time to talk through them. There will be a quick cast within the next week coming out. There's a lot that's coming out from interior designers, air handler design systems folks, and so forth that I've listened to and read that we're putting together into a resource for you to take a look at as we start talking about post-COVID and design and how do we change our spaces for the better. For example, Perkins Eastman has an excellent guide that's linked in one of these. If we can head to the next slide, you'll see more links made available there as well. Humidification, purposely designed spaces. There's a lot to consider, and it's very overwhelming. So what I'm trying to do is boil it down into its essential pieces of what these different resources offer. I saw there was a question. Hold on one second. Oh, sorry. Just a great comment from Ben. Ben, did you want to share more about what you just posted about senior living contracts?
I think Ben had to drop off for another appointment.
Gotcha. Sounds good. Well, then I'll wrap it up there. Thank you so much. It's great to be with you. When the new quickcasts and that new CDC special meeting date is announced, I'll share them broadly and hope you can join us. Thanks so much, Dana.
See, that was great. Thank you so much. A lot of great information. I know we're at the end of our time. I want to make sure that everybody's questions have gotten addressed. Chris asked, has anyone modified testing requirements for team members who have not participated in the vaccine process? So I want to just open it up for anyone to respond to that or to ask or offer any comments just as we wrap up here at noon. Okay, Charmaine says, we do have staff that will not get the vaccination. We did not mandate the COVID vaccine. How do we respond to residents and families that try to bully or intimidate our staff trying to find out if they're vaccinated? Dee, did you want to respond to that? You sort of mentioned that issue earlier.
Yes, definitely. Ben's approach, I'm sorry he jumped off, but I really appreciate Ben's approach, which is that direct approach. This is what we will share. This is what we will not share. And setting the expectation, I think, very clearly. I would not hesitate to tell residents, look, just like we have an obligation to you, we have an obligation to our staff to protect their privacy and their health information. And not only do we have an obligation, but we're required as employers. I know other members who have had those conversations with residents. I've done that myself in completely different setting, non-COVID time, but other instances where residents have wanted to have that private information about the status of staff and so forth. And it's not appropriate. And if you feel that, and the word bully here really jumps out from Charmaine's description, if you feel like they're crossing a line, it's appropriate to have a private conversation and say, this is not acceptable. I understand your concern. I know why you're anxious. But this person has a right to their privacy and their health information being protected, and we have to uphold that right. And I liked what Ben had to say about drawing that line and saying, if you want to decline service, then you're declining service across the board, and that's your choice. But then that means no housekeeping service or whatever it might be, and having that really clear, compassionate, but transparent expectation set. That's what I've seen done successfully with different members.
Yeah. Thank you so much, Dee. Ryan says, I emphasized to residents' families that we did not mandate it and gave them a choice, just like we've given residents a choice. Well, we are out of time. Some really great information. Thank you all for sharing today. We really do appreciate it. We do not have a call planned for next week. For March 31st. If things change, we'll let you know. But we are here for you, your LeadingAge Virginia team. So please let us know if you have any questions or issues that you would like addressed in future calls. So thank you all so much for joining us today.